Much of this talk is sort of based on a recent document that we put out on behalf of the American Heart Association, Polygenic Risk Scoring for Cardiovascular Disease. And this may feel a little bit like science fiction, but the ability to use genetics to advance cardiovascular care has substantially advanced, and there are many different reasons why. In a couple hours, I'll be giving a talk just sort of giving a broad overview on how one can think about using genetics for cardiovascular disease, because there's a lot more that we can use these data to understand human biology. But now, this represents one of the opportunities to translate these findings directly back into the clinic. And some of the reasons why this is not too far ahead of its time, or at least we don't think it's too far ahead of its time, is that genetics is actually already out there for many of our patients, particularly in the US and increasingly across the world in many different forms. One of these forms is direct-to-consumer genetic testing companies. Consumers, our patients, can go out there circumventing physicians to get actually pretty broad genetic profiling. And in many of these companies, increasingly, the companies are providing risk assessment tools based on the genetics. And it's kind of on us now as clinicians to try to interpret that for our patients and try to understand, is this information that we should just ignore, or is there an opportunity here? Additionally, across the world, biobanks are becoming increasingly large in size. There are kind of two flavors: population-based biobanks that are happening, recruiting, agnostic, external to healthcare-associated settings, but primarily so in Europe and in US, many of these biobanks are happening within healthcare institutions, providing opportunities of intersecting this new biomarker with clinical care. Now, these are graphs largely reflective of trends in the US. And the one that you'll see on the left is deaths attributed to cardiovascular disease. And this is a very familiar graph for those of us who study cardiovascular epidemiology in the US, where they're in the early part of the 20th century, rising concerning trends in cardiovascular deaths, and then starting from the mid-20th century at a high level, a persistent plateau. Now that is progress, but it's largely stalled progress. Cardiovascular disease retains its dubious distinction of being the #1 killer in the US, and then actually over the last 2 to 3 decades across the world, non-communicable disease, primarily complications of ischemic heart disease, have become the leading killer of death. So not just a US problem. Importantly, with stalled progress and an aging population and a larger population, there's substantial rises in costs. And the approach to identify individuals at risk and treat them has, again, largely been the same for at least the last half century. So we and many others have been really interested in trying to understand what are the other opportunities to curb those worrisome trends. One particular approach is to use genetics to understand cardiovascular disease. The flavor of this kind of research are so-called genome-wide association studies, where in the population we broadly profile genetics, and then we compare each of the individual alleles and their frequencies between individuals who have heart disease and those who don't. Now, many of the genes that emerge map to well-known cardiovascular disease risk factors, but actually about half of them don't. And there is a body of work to try to unpack how each of these genes influence heart disease, and we'll talk about that more a little bit later today. But regardless of mechanism, one can actually take that data to try to advance risk prediction approaches. Now, risk prediction has been the cornerstone of preventive cardiology, to try to prognose, at least over the course of 10 years, what is the likelihood of a patient to develop cardiovascular disease, and using that information in a shared decision-making approach to try to understand what are the appropriate lifestyle approaches to modify that risk, and importantly, as cardiologists, for whom does statin medicines and other medicines make sense? So the basic approach for polygenic risk scores, that's the name of using genetics into a single score, a single number that we apply to patients, is we take the information from genome-wide association studies and then use that information in usually 1 or 2 additional populations to find the right combination of alleles, reweighting the weights as well. And then in the end, we have a single score that is applied. Now, much of this information, one might think you can just simply get it from asking a family history, about a family history of heart disease. Now, it turns out, quite surprisingly, is that, there is a correlation between a self-reported family history of heart disease and these genetic risk scores, but it's not a perfect correlation. As a result, both sets of information are actually pretty complementary in informing who is at risk for heart disease. And this shows that, family history not only is probably capturing some genetic information, but is actually capturing a lot of shared non-genetic features that are influencing risk for heart disease. So importantly, family history is an important piece of information, but this is providing more information above and away. Now, if we look at it in the totality and compare it with conventional clinical risk factors, this is one such study that was done in what is called the UK Biobank in its earlier iteration of about 150,000 residents living in the UK. And on the plot on the left, you see the additional value of having genetics incorporated on top of clinical risk factors. But what I found pretty compelling in this study is when the investigators compared genetics as a risk factor compared to the risk factors that we've used for the last 50 plus years. And the metric that they look at here is the C statistic, basically the likelihood of identifying individuals who are going to get events and not identifying individuals who are not going to have events. And that's the C statistic here. And then you find that this genetic risk score is at least on par individually with each of these clinical risk factors. What is also pretty interesting that I think most people don't appreciate is that the genetic factor is available theoretically well before any of these risk factors are abnormal. So this study is done largely in middle age when the risk factors are most optimal for predicting risks. But we find above that, this is actually still providing information even into middle age. Now, we recently looked at this, is there an opportunity if we happen to know genetic information because so much of this profiling is being done in these biobanks. This was done in 3 different geographically distinct biobanks in the US. So geographically distinct and actually pretty distinct as far as the diversity of each of these biobanks. So we have ours in New England, also in Pennsylvania, and then another one in New York. And despite all the things that we do at these major academic medical centers, it was clear that there is a risk signal. Individuals with coronary artery disease are at higher risk. And if we compare their eligibility and risk factors for statin therapies, is not actually identifiable by individuals who had high genetic risk versus not. Turns out that even though that some of these alleles do influence cardiovascular disease risk factors, they don't do so that strongly. Individuals at high genetic risk only modestly have an increase in their LDL cholesterol. So as a result, if you look at their predicted risk is pretty similar between them. So even though there is a risk signal, they're not identified to be more likely to be eligible for statin therapies. Now, importantly, we are interested in trying to apply these tools in diverse populations. A major limitation in the field is that most of the studies, the gene discovery studies, happen in individuals of European ancestry. Those have been the legacy of the most robust epidemiological studies, and so substantial initial investment in this kind of molecular profiling were done in these cohorts, but we can port those tools and look at data sets that are being developed in non-Europeans. This is here looking at 2 data sets. So one is, again, the UK Biobank, now 500,000 individuals. Small fraction, about 5%, are non-white in the UK Biobank, and a substantial proportion of them are actually of South Asian descent. These are primarily Indians living in the UK. And the BRAVE cohort is a cohort of Bangladeshis living in Bangladesh. And we find that the score is actually predictive in these individuals. And this is important because we know in the US and outside is that individuals of South Asian ancestry have higher cardiovascular disease risk. It is not captured as well by just traditional clinical risk factors. And this is among the tools that we can use to identify patients of South Asian ancestry who are at higher cardiovascular disease risk. Now, there have been a lot of investments by the US and by the UK in developing larger cohorts, diverse cohorts, Major limitation is that they are still pretty not diverse despite these investments. And a major limitation in the diversity is actually in Asian Americans and in South Asians. So we have developed an initiative in the US to identify individuals of South Asian ancestry to use these kinds of tools. Now, one can align with some of these concepts, and I'll speed up a little bit just in the interest of time, is that in the US and also in Europe, there's this term, the risk enhancing factors, so additional novel biomarkers that upclassify risk. Genetic risk scores upclassify risk similar to other risk-enhancing factors. And if you look among individuals who have not had events, who are in this borderline to intermediate range where there's clinical equipoise, about 4% of individuals will then be newly recommended for statins. So you're not making dramatic changes, but there is a subset where this will be helpful. In prospective studies, if you return this information back to clinicians and patients, those who are at higher genetic risk generally have lower achieved LDL cholesterols. And interestingly, if we go back into clinical trials and we see the people who benefit the most from statin medicines, individuals with the highest genetic risk benefit the most from cholesterol lowering. It's an interesting interaction because individuals generally who have diabetes, smoking, these are individuals that were more aggressive with medicines, their relative risk reduction's the same. Here, the relative risk reduction is different, so it's magnifying the number, the absolute risk reduction, and therefore shrinking the number needed to treat. That's not restricted to statins. Actually, we see that with PCSK9 inhibitors, so it suggests that these patients are actually going to benefit the most from cholesterol lowering. Now, I'll quickly touch up, I know I'm going to be a little bit over time, but I think that the benefit for this kind of tool is going to be in younger individuals. Again, in the contemporary iteration of guidelines, which has been, about the last 40, 50 years, is we've been using as an isolated factor for early pharmacotherapies has largely been restricted to individuals who have severe hypercholesterolemia, class 1. Now, interestingly, when we apply this genetic risk score and we predict risk, individuals who are at the top 5th percentile, it's actually much more common than severe hypercholesterolemia, have the same risk as severe hypercholesterolemia, and as I showed you before, they actually benefit the most from cholesterol lowering. When we look at the comparison between clinical factors and genetic factors, for individuals who are younger, by far and away, the genetic factors are dominating as far as the ability to predict risk. That decays a bit in middle age, but again, as I said, the genetic factors are available at birth. And then lastly, I'll leave you, when you look at even younger individuals and they're 18 and 30-year-old, again, a deficiency of clinical risk factors, these individuals are identified as being at higher risk. Okay, and then I'll wrap up just in the interest of time. Thank you so much.